Welcome to this edition of Clinical Clips, an accredited continuing education activity. This brief expert video will spotlight the daily hot topics from the conference.
Welcome. Thank you so much for joining me. My name is Dr. Jean Elwing, and I'm here at CHEST in Nashville, and it's Monday the 17th, and we have some very exciting pulmonary hypertension information to share with you. First, I'd like to mention Dr. Prakash Giri's presentation on therapy for pulmonary arterial hypertension. He reviewed the data on single, dual, and triple therapy and showed us that risk assessment is imperative in our patients. High-risk patients have very poor outcomes, but through aggressive therapies, we can change that risk assessment and then change the overall survival of our patients. He reviewed several studies. He reviewed the Ambition study, the Triton study, and Griffin. And he showed us that upfront combination therapy, as seen in the Ambition study, delayed clinical worsening. Also in the Griffin study, add-on therapy helped improve outcomes overall for our patients. And this information changes how we manage patients and drives our guidelines. And also Dr. Ray Benza presented a very provocative trial on CS1 in pulmonary arterial hypertension patients. This is the first epigenetic modulator being evaluated for pulmonary arterial hypertension patients. He is going to use cardiomems in this study for real-time monitoring of hemodynamics in these patients, something novel and very exciting. He will look at patients with pulmonary arterial hypertension who have functional class 2 and 3 status and add this therapy. The primary outcome in this study is to look at safety and tolerability, but the secondary endpoints will be things like actigraphy, risk assessment, and hemodynamics. Dr. Kelly Chin presented on the CTEPH registry, looking at quality of life. She evaluated patients who were operable and underwent surgery, operable and who did not undergo surgery, and those who were inoperable. She found that the patients who were operable and underwent surgery had the largest impact in terms of their quality of life and their pulmonary hypertension symptoms. This was significantly different than those who were inoperable or those who did not undergo surgery. And I presented data from the Freedom EV open label extension trial. Freedom EV was a study of patients with pulmonary arterial hypertension who were on monotherapy who had either oral treprostinil or placebo added and were followed for clinical worsening. Treatment with oral treprostinil was associated with a decrease in clinical worsening over that study period. Patients who did experience clinical worsening during Freedom EV or those who completed that study could enroll in an open label study. That open label study followed patients over up to 108 weeks. During that study, patients were followed for walk distance, NT-proBNP, as well as functional class, and safety was monitored throughout. Those individuals who previously received placebo during Freedom EV were evaluated and during the open label had improvement in all parameters: walk distance, BNP, and functional class. The patients who had previously been treated with active oral treprostinil in the Freedom EV study also enrolled in the open label extension. Those patients also experienced improvement in walk distance, NT-proBNP, as well as functional class. Now, some of those individuals did have the opportunity to add a third therapy during the open label extension if the investigator felt that that was indicated. The addition of that third therapy was associated with a significant improvement in their 6-minute walk distance of 116 meters and marked improvement in their functional class. They looked at adverse events in patients that had that third therapy added for pulmonary arterial hypertension, and it was relatively well tolerated. Overall, 24% of the participants who initially received active oral treprostinil in Freedom EV, who then enrolled in the open label extension, had a third oral pulmonary hypertension therapy added. Of those patients who experienced clinical worsening in Freedom EV and then enrolled in open label, had a 56% improvement in their functional class. Of those who did not experience clinical worsening but entered into the open label at the completion of Freedom EV, maintained their functional class in 89%. Although there were mild increases in AEs in the patients who were on triple oral therapy in the Freedom EV open label extension. This was relatively well tolerated and appears to be an option to be used with oral treprostinil in our pulmonary arterial hypertension patients. Thank you again for joining me. I will be seeing you on Wednesday the 19th with additional information from CHEST here in Nashville.
We hope you found this activity useful and educational. To receive continuing education credit and to download your printable certificate, please return to the activity webpage and click on the Claim Credit button associated with today's clinical clip.